Session starts in 5, 4, 3, 2, 1. Take off. That. Okay, so now we're going to talk about evaluation plan and follow-up. Essentially just talking about data. And so my talk is data, measure everything. I'm done. Next. No, okay, sorry, I was kidding. Yeah. So when you're trying to build a medical home like this, you have to essentially start with the end in mind. You think about what you're trying to do, why you're trying to do it, and who are the stakeholders for your project. The way that we approached it, we used PDSA cycles, which essentially means plan, do, study, act. We had goals that we were trying to hit. And like Shirley mentioned, on Tuesday or Wednesday, we had a QI team that came in, used the DMAIC approach to help us standardize, plan, and set ourselves up to measure our outcomes and our processes. And speaking of processes, we used a lot of visual diagrams, Gantt charts to get an understanding of what we're trying to do, where the holes were that we were trying to fill, and how we were going to approach to meet those needs. Now, speaking about data, it can be sometimes overwhelming. You can look at it. This is just an example of what the type of information that we captured, but it can be a lot. And when some people think about data, they just get flustered because it's a wealth of information. Ideally, in a perfect world, you want to measure everything because you don't know who is going to ask what and when they're going to ask it. But the amount of data that you measure somewhat depends on the size of the organization. So don't be discouraged when you think about what you might want to measure and how much it is. Think about what is the minimum amount of information that you can collect that can make an impact and plan for that. You can always scale up. It's very, very easy to scale up. So at the very minimum, build your data structure or your platform based on the organization's values. If your organization cares a lot about, length of stay, number of patients, build your data structure around it. Don't try to go and try to collect vitals or blood results or any of that sort if it's not meaningful for your organization, because you'll be wasting your time, wasting your resources, and shrinking your potential. So align your goals with that of your organization, and that way it's going to go from a big picture to a smaller picture and something that is feasible. I have a list of the type of data that we collected for this project, but this is just some of them. The list is really long and never ending. I just wanted to show you what it could be. And we wanted to have program level data that was literally what the navigators were doing, what the survey, patient satisfaction surveys, trying to understand how time was being spent with patients, how the navigators were spending their time, how our social workers were spending their time, what our patient population was doing in the hospital, were they coming to the appointment, how often, were they canceling, were they not showing up for our prior authorizations. We're also trying to track how often a patient was filling the prior authorizations. Did they have any issues filling it? Were we able to reduce time in the past where it was taking a lot longer to get those approved, to reducing the prior authorization approval time? And you can see, and that's just on a administrative level, not even regarding patient information, because that was important to us. It was important for our administration. It was important for our department because they wanted that data. So again, align your data collections to the values and the needs of your organization. Training and orientation. For this training, I believe we sent you guys an email. You were asked to take a pre-test, an assessment, and then after this, we're going to send another email and say, take the test again. And we're not trying to see who got it right, who got it wrong. We just want to see what you've learned over time. Same questions, but for some people the answer might change. We just want to see where we're successful in how we deliver the information to you. And that is also true when you have a sickle cell medical home. You set goals, you have a plan on how to measure if you are able to attain those goals. You run your medical home, you run your process, then you measure again, did I hit those goals? Did I make an impact? And that's somewhat what we did. I don't have much after that, but I just really wanted to emphasize the fact that data can be overwhelming, it can be scary, but if you align your data collection tools or your data collection structure to the values that your organization or your institution has, you can bring it back to something that you can do, and you can effectively do it that way and be very impactful. Yes.
If your organization is not strategically collecting information,
yes,
and yet you would like to independently, so you don't really have a database that you're putting things into.
Yes.
What do you suggest? I mean, something as simple as a spreadsheet.
Yes.
There is no small way to collect data. Whatever you can get is likely going to be impactful somewhere. A spreadsheet in the beginning, and there are a lot of softwares out there that are free.
But don't spend money.
Mm-mm.
Okay. Oh yeah.
Yeah.
If there's free software, now what software are you thinking about, Daniel?
Actually, RedCap is open to CBOs. Yeah. You can have if you're a CBO and you have a 503C, the 501(c), it's free for you. The 501(c), it's free for you to use. If you are aligning yourself to an institution like VCU, it's definitely going to be free for you. Cost-wise, I don't know exactly what it costs when you're a standalone institution without any affiliation to a teaching university. Other than that, if you even go to Microsoft, you can download Microsoft Access for free, and you can use it. It comes with the platform of services.
The three tools that I would recommend, not being a digital dynamo like Daniel is, I would say Excel is the first starting place. You can play around with it and you can manipulate it, and what you see is what you get. In front of you is what you're going to see, and is what you're going to get. It also requires more energy because you don't get any reports out of Excel unless you make it give you reports. But it is a starting place. So I'm recommending, you didn't ask for this advice, I'm recommending you get somebody who really knows how to make data sing, and you collect what it is you think you want to collect, and then give it to them and say, can you make this? That's what I'm recommending. Unless you already are a data guru, I'm recommending that. Now, why don't I recommend Microsoft Access and RedCap? Daniel?
Access can be difficult to manage. RedCap is definitely not user-friendly. It is not user-friendly.
I think that RedCap and Access are high-end organizational level tools which are for big data projects. Excel is what I use for a 50-person data collection project. It's my first 50 patients. I might decide I want to get their first name and their last name. I might just want their last name. I might decide I want their social security number in the middle of the project, and I got the permission to get it. I can add that in. I might decide I want to know what their mother's blood type is in the middle of the project. I can just add that in. If you want to do that in Access, or if you want to do that in RedCap,
it's going to be headaches. Something else that is free and that a lot of people use is Google. Google has Google Forms. You can collect data and it will decent reports.
Okay.
Or automatically. You don't have to go in and tweak. It's going to give you frequency, how many people filled it out,
Okay.
what is the average, what is the range. It's very simple. Yeah.
If you already have Constant Contact, you do surveys out of Constant Contact, and that'll port into Excel for data review.
More about that. I don't know that.
Constant Contact is a platform that's used to communicate with your customers or parishioners or whomever, and it gives you kind of a format where you can create certain templates where the information behind it, like your logo or city, state, and social media stuff is all the same, but the context is different. And you can have a database of email addresses that you just drop into a different area of that same program, or it's not even a program, it's a web-based thing. And you can parse those emails to 18 to 35, 36 to whatever, and target who you send messages to, and it records what you use, and then also you can have it where when the emails are sent, it'll give a notification if they've opened it. So you'll understand what your reach is. And then if they do open it, you can have another mechanism where it'll send them a follow-up. So it's good. Yeah.
Thank you.
I would also mention SurveyMonkey. Most
That's
of us
another
have
one.
probably filled a SurveyMonkey out for somebody else by now. And I like SurveyMonkey because you can design your data collection form on the web, and you make up your survey, and you notify people, like you just said, notify people that you have the survey and ask them to take it. And then SurveyMonkey assembles the results for you. So, and it may not be the way you want it. I agree with that.
Yeah. It's there.
Now, I do not know whether SurveyMonkey results can be exported into Excel or not. I don't know. But
Yeah. Yeah. And also, just by being here today, if you plan on collecting data and you're not sure, you can always reach out to us. You can let us know what type of information you want to collect, how you want to collect it, how often you want to collect it, and we can work with you to help you build a template. And it's likely that we might already have a template that we can just share with you. Because we do want you to go out and try to replicate this and collect information, because we will reach back out to you and try to see how you're doing and how, if we have been able to help you empower other people. Yeah. Anybody else? All right. Pass it on to John.
Shirley's already cleaning up. I know. All right. Whoop. Whoop. I gotta go back. Oh, where do we go? Bye. All right. Bear with me, because we didn't finish up. Just a few slides. Oh dear, where'd they go? Where'd my slides go? Oh shucks. Where is Daniel left?
you changed the order.
Yeah, but see, we didn't finish. Okay. I gotta learn. Oh dear, let me see. Did he go? All right, we're gonna do something here. Oh, there it is. He did. He changed the order on me. All right. I'm not gonna belabor this. We could do a whole conference on burnout and compassion fatigue, but we're not. But I do want to bring up the concepts because I think it's important for us. What do you already know about burnout? I know you've all heard the term, right? It's it's coming. All right. Burnout, just the definition, it's the emotional, mental, and often physical exhaustion. I guess we could probably fit that bill right now, probably, right this moment. But it's usually prolonged, repeated stress in the workplace. Burnout is associated with the workplace. It is not simply working long hours. And you, I know many of you, I've heard it expressed. You love your job, you're committed, you want to get up and go out there and do what you need to do. And you may work long hours, but you still come in and do it. It's important. All right, you're doing important work. Burnout is not trauma related, okay? And that's going to be important in a minute. It's related to work stress. I think we always have phases, don't we? But we have phases of burnout. And that when we first go to a job, have you experienced this? You kind of have a honeymoon phase. It's like all the excitement of getting the job and getting the offer and doing orientation and starting this new job, meeting new people, and everything is great. And then as things progress, it may be 5 years later, it may be 2 months later, there's an onset of a stressor. It could be one, it could be several, and then it can become chronic. And this is where burnout comes into play. And then it becomes habitual, and that it's a constant burnout, emotional, physical, and mental stress and burnout, just exhaustion. Who's at risk? Look at this list here. Now, please understand the people that do this probably are not aware of the community health worker, patient navigator, health navigator role, so therefore you're not on here, but would you not guess that you're probably right up there with the physicians, nurses that are healthcare providers, okay? I certainly, and social workers, see, we're all up there, so I think you're up there right with us, all right? But I thought it was interesting, teachers, principals are pulled out even separate as being up there. And I guess in today's world and what we hear almost every day, they do have some real stressors on their jobs. Retail and fast food. And I'm thinking, well, when you think about it, a lot of those young people out there working fast food, minimum wage, if that, and what they're having to put up with. All right. Police officers, public accounting. I thought that was an interesting one, but these are the top ones that are found in the literature.
Preachers.
Huh?
They forgot preachers.
Forgot what?
Preachers.
Oh, preachers. They may be lower on the list, yes. All right, compassion fatigue. How many of you heard that term, compassion fatigue? Maybe, all right. This is a relatively new term that's kind of popped into the medical and nursing literature. It's a state experienced by helping professionals, so it's related to us folks. It is a gradual loss of compassion. We've used that term a lot, you know, but over time we are observing that folks like you that are working in the helping professions are stressing out, and it's not burnout, it's compassion fatigue, and it is related to workforce trauma. Now, trauma, I'm defining very generally. It's not just accidents, okay? There's a nurse up at UVA, which is right down the street from us, who's developed a whole career on compassion fatigue. And I've been very fortunate. I've had a chance to hear him speak. It's fascinating what he has learned. And one program he put in place at UVA has to do with ICU nurses and ER nurses, and that the trauma of continually seeing death and trauma and gunshot wounds and families and total stress come in, and then trying to deal with that. And also, he's done some work in hospice care, where every day you're dealing with people dying. So what he's developed is a program where, like in an ICU or in a ER or even on the hospice unit, where when the patient dies, they do a little step back, and the team gathers, and they spend maybe 3 minutes, usually no more than 5 minutes, just saying, this is how I'm feeling, I'm sorry to see this patient, I had a particular interest in, you know. Everybody gets to just take a minute and just honor the moment. And he studied this, and guess what? That makes a difference. Something so simple and doesn't cost any money. So compassion fatigue, you're going to see it. Some of the signs of compassion fatigue, and I got a feeling that you might be seeing this. Chronic physical and emotional exhaustion. In other words, you never can seem to feel good about getting up and getting rolling. You're just tired. Sleep doesn't really help. Difficulty sleeping. Maybe you're waking up in the night and not able to get back to sleep. Depersonalization. I have a feeling that some of you have seen this in some of the nurses that you've run into and encountered on hospital units and in ERs, maybe some of the doctors too, where they're just functioning rotely, just doing their job, you know. They come in, they take your vital signs, they hardly even talk to you. In fact, they may not. They just come in and take your arm and do their thing and walk out, and you're like, huh? You feel very depersonalized, okay? Poor job satisfaction, not happy. Irritability. We see this and that all day long. This person is very irritable. Nothing seems to go right. And maybe it's not, but there's a difference. And I'm sure in your own life, there are days that you're just tired, your family's driving you nuts, you find yourself really irritable, it's mama this, mama that, mama this, mama that, and you're just like, would you please stop saying mama? I don't have children, but I know what it feels like because I've been around. And, I have a new dog, and it's like, God, Cooper, can you not just go settle down for a few minutes, I'm tired. Okay, so it's that constant. Headaches. Now, interesting, the literature says weight loss, which I can see that. But I could not find, and if I was exploring this more deeply, I would really look. I think weight gain, which should be on this list. I'm personally involved with a certain weight loss program, and I go to my meetings, and I swear, this is part of it. It's that using food to self-medicate. Yeah. So it'll be interesting as the literature expands on this. But anyway, and a feeling of self-contempt. We start internalizing some of all this negative behavior. So it's like, and I even think in seeing it, maybe even a sense of inadequacy. Maybe some of you have felt this, that you've worked so hard and you're just out there and you're just, beating the bushes and you're working with your patients and you're doing this and you're doing the political stuff and you're doing this over here and you're having events to raise money and and then you say, well, gosh, I just must not be very good at this. I can't seem to get on top of this. So those feelings of inadequacy begin to seep in. So, actually, there is some literature out there, but what I think I'd love for you to do, to take a few minutes in your books, and it's toward the end. It's actually, I believe, right behind the sample job description, and it's called the Professional Quality of Life Scale. It looks like this. It's got a blue bar at the top. See if you can find it. Because I want you to take it. Oh, good. You found it. You found it. Let's just do it for fun. Take a few minutes. Anybody found it here? I know I'm going to do it. That's why I have to really shuffle and find it. You guys will see it. Okay, go on and take this. Just personally now. I'm not going to be asking you to share your personal information, but take this. This tool was free for us. All we had to do was give credit. So this is available free if you want to use this to stack. It's been, validity and reliability has been established. So I'm going to shut up for a few moments. You're not supposed to be comparing answers. I've already done it, so that's why I'm walking around. Go on and do your score if you're there. Okay, for the sake of time, I'm going to call so we can finish up. But hopefully, if you're not quite done, you can finish up later because this is not a quiz. Did some of you find out something about yourself? Anybody willing to share? I see a giggle over there.
I thought I did pretty good, except when I added up my scores, I'm not happy with my results.
Oh, meaning what? Not happy? I mean, you thought,
Well, I thought maybe I fell in average, but I fell in low.
yeah. Wow.
I mean, I'm surprised.
Yeah, you're surprised. So you're surprised. All right. Now, this may change. It does change. Yeah. I mean, and it depending on if you've had a really bad day at work and you come back and there's something different. But I think it is kind of something that you might find useful in working with colleagues and staff, and to differentiate between the burnout versus compassion fatigue. If it's burnout and it's stress, it's so related to the job that this is when you really need to examine what's going on in the job. Is it something you can control, change, or is it time for you to move on? Or is it because of certain people or whatever? So it's a time to reflect on how you need to deal with that. But some of the typical things, you know, is to stop, check in with yourself, take a break, take personal, and that should be inventory, by the way, not inventor. When is it time to talk out versus pause and regroup? We had an example earlier that somebody experienced something and they immediately took that action and they needed to do that. Otherwise, it could have just festered and got worse. So knowing when to regroup and step away versus when to go on and be assertive, hash it out, get through the go for the walk, do something different, bring it up in a team meeting. I have been involved in I like the team meeting. And then there's times if it's really between individuals. I'm fortunate when I was working with the state, there was a whole third entity, not our human resources, and you could go to that, a mediation. And I have to admit, I went dragging. I did not want to do this. Why should I do this? This is a, difficult employee and we're having issues and blah, blah, blah. But I went because after all, that was the right thing to do. And it ended up being the best thing in the world because we had a third party, didn't know us, and really did some homework to get ready. There were some things that we did. And then when we actually had the meeting with this mediator, it made all the difference in the world. And this person and I could learn how to work with each other, and we both did some give and take, and it made for a much better work environment. And of course, everybody else noticed, oh, you and Mary are getting along so much better. What's the deal? And we just kind of smiled and went on because it was all kept confidential. So, and I made that up, by the way. I mean, I didn't make the story up, the name up. How do we manage stress? And we all are going to be different, but there are things we can do. And believe it or not, some of these things do work and have been studied and are out in the literature. So a mindful break. We've done a few of these. I mean, one time we did our one where we did our deep breath and everything. That's like having a mindful break, isn't it? I love this proverb. It's a Japanese proverb. Fall down 7 times, get up 8. Being some of the stuff that I do, I really use this proverb. All right, resilience is another concept that I bring into the picture because when I went to the literature on this, resilience is there in the medical literature. And it's all about how we bounce back or adapt to our situations. Because we may not be able to just walk away from a job or walk away from something. We've got to figure out how to get in there and work it out. So bouncing back or adapting and doing this either through our physical, emotional, mental, or spiritual selves is one way that we can deal with this. So some of those evidence-based strategies in your notebook, there's another sheet called the self-care checklist. Don't intend for you to do anything with it today, but it's there. This is a checklist that was developed by a nurse, but she's just left it out there in open domain. I got it at a conference. There was nothing on it, so I'm using it. Yeah. But in going to the literature, most of the things on this list have been shared in the literature as being effective, evidence-based strategies to manage both burnout and compassion fatigue. So self-care education program, actually there were several articles about education programs for nurses and social workers where they went into hospitals and actually educated people about burnout and compassion fatigue, talking about it, bringing that awareness, and then having people just have a mechanism to talk and share and say, yeah, I'm just really struggling lately. And believe it or not, a 15-minute, this one was done with nurses' aides in a nursing home. A 15-minute education twice a week for like 3 weeks had major, and they used this form that you just did to look at before and after, had positive impact. You know, that's not a lot of expense. I mean, 15 minutes to take a nurse's aide out. And the same, very similar research was done with nurses and social workers. The social workers were one who worked for like CPS, very stressful. Remember, Shirley talked a little bit. She has a history working with that. Very, very stressful kind of patient population to work with. Reading. How many of you read for fun? Yeah, isn't it nice? When I was working, I never got to read for fun. Believe it or not, in the literature it is shared that those people who read for fun handle stress and compassion fatigue better than those who do not. One interesting study was on doctors, and it was actually reading for fun that was, I guess, a mindful way to escape and enjoy. So you should never feel guilty for spending that even 30 minutes just reading for fun, all right? And I learned that lesson. I now read every night pretty much for fun, and I love it, and it really helps. Exercise. We don't have to, y'all all know that exercise, everybody's saying you gotta do exercise, gotta do exercise. Well, you know, it doesn't have to be going to the gym and paying a big price and pumping iron. It can be anything from walking in your neighborhood. As I said, I have a fairly new doggy, and I go out and run with him. You know? So we're running around the yard. I guess my neighbors think I've gone kooky, but you know, I throw the ball and he goes and runs, and then he runs around with the ball, and we just have all kinds of fun. But that's a wonderful stress reliever. Plus, I'm getting some movement or exercise. Talking with someone. Now, doesn't that seem simple? But for some of you, you may be fairly isolated, especially if you're not in a big group and you don't have a lot. And so it does make sense that you've got somebody to talk with. When this team started, it was Dr. Smith and Shirley. There were a few students that floated in and out. I remember we had Donita, who did your IRB stuff, kind of was there for a while. So there's been various people that have kind of come and gone, but it's pretty much been Dr. Smith and Shirley until fairly recently. They didn't really have anybody to talk to. You know, Dr. Smith had to go off and do clinic, and Shirley sitting there. So my part-time role over the years, I think, has been at least something that Shirley had somebody to talk to on occasion. And so there were times that, I'm telling stories on you, Shirley, that I would go down to the office, we'd do what we needed to do, and then we'd sit and eat lunch in her office, and we just would chat. Well, believe it or not, that actually should be encouraged and a useful strategy to help with burnout and compassion fatigue. So sometime you may need to build that in somehow. Because I know in some of your smaller groups, you just don't have that. When, like nurses on a unit, they have a lot of different nurses to choose from, so they may have their 1 or 2 buddies, all right? Eating a healthy diet. Now this is so silly to say, but you know, it's true. Eating a healthy diet. Pursuing hobbies. We found out last night that many of you have some really neat other cool hobbies, you know, skydiving and the craft work and all this neat stuff, singing, and I mean, that's wonderful. And that is actually a wonderful way to help with some of this. And then support groups. Now, y'all do support groups, some of you, for our sickle cell patients, right? And you do them, you understand the role of a support group. So I don't have to talk to you. It's like singing, you know, singing to the choir. But obviously support groups. So the self-care checklist I put in there in your portfolio. At some point you may want to take a look at it, and you actually just kind of go down to see, do I do any of these things? And as I said, most of them are evidence-based. Not every single one, but it's just because it hadn't been studied, okay? I couldn't find a study, let's put it that way. All right, here we go. Daniel's already done his thing, so unless, obviously, there are other questions, but the one thing you agreed to when you said you were going to come join us, oh, you know what? I haven't done the education part. I'm suffering from burnout. Okay, but for this, we have set up December the 3rd at 1 p.m. Eastern Standard Time. Remember we talked about our follow-up phone conference? So put that on your calendars. We will send you reminders. Yeah. Yeah, it'll be in another whatever week. It will not be today. It will not be today. All right. Now, we changed things around, so you got to hang on a minute. And see, Daniel changed me around here. I got to go find my slides. Because I'm going to move right on into the education part so that we can be done on time. I promise you I'm going to be done on time. All right. So we kind of switch gears now. Is there any comments or anything about the burnout, compassion, fatigue? No, you did it. You didn't do me though. But anyway, that's all right. No.
There can never be. Burnout and burnout.
Okay. You done heard me talk about all of these states and what they're doing, but it's best that we can find out there's no national standard training curriculum for community health workers. There's a lot of good trainings out there, or could be good trainings. CDC has a bunch of trainings for all the diabetes, hypertension, and some of that. Remember we talked about Coleman model. He does training in Colorado. We found out through our Sickle Cell Association there's a training there. We've not evaluated it. I can't speak to it one way or the other. But there really is no standard CHW training in the country at this point in time, to the best of my knowledge. So in trying to figure this out, here again, we went back to the literature, because when we first started our project in 2012, or when we wrote it, we did the training in 2013, we were just, as I said, we're floating with the seat of our pants. We didn't know. So we used what was out there, and then we put together what we thought was an appropriate curriculum. And as Shirley mentioned earlier today, it has evolved over time. But in looking at the literature, these are the topic areas that seem to be emerging as those things that ought to be included in a good CHW curriculum. And I've just listed them. They look very familiar because they are derived from those core competencies of which we've shared with you more than once in the last few days. And you'll notice, does this not look familiar to what we just did? Duh. Now, interestingly enough, as I sat here and listened to us and thought, I've made notes through my whole notebook about, we need a little more of that or whatever. So I'm hoping you will take this very seriously and give us that input on your evaluations, okay? We need it. If you've sat here and said, you really should have hit on that, or you didn't even mention this, let us know that. And then as we move forward in this next year and whatever happens after this, that information will be used. But this is the best that we knew when we came about doing ours. Included in the curriculum matrix, of course, for sickle cell, and this is through the work that Dr. Smith and I had done with the Sickle Cell Association, is these are the key things that need to be in a sickle cell community health worker program. So obviously, overview of the disease, the different treatments that are available, especially now, being that there's more than just one approved drug. The medical complications, remember Dr. Sisler did a nice job. You need to have somebody to help with that. And I know you're in areas, and you know what? If you don't have that expert in your area, this is where ECHO comes in. This is where we come in. This is where telehealth, we can do some telephonic consultation. I hope I'm not promising the... No.
If you are a PCORI site,
Oh.
and you are in the peer mentor arm, if your site is in the peer mentor arm, you're going to have a special bonus access to peer mentoring materials that can be used with patients. It's a curriculum. Looks very similar to that. And it's the peer mentor saying to the mentee, hey, like you, I have sickle cell disease. And in my experience, this is what's worked.
Yeah.
What's worked for you? Maybe you want to try this. Maybe you want to try that. That's the approach the peer mentors are taking. So they are, guess what? CHW type 1.
Yeah.
Category 1.
That's what we think.
The peer mentors in PCORI are CHWs.
Mm-hmm.
And so their curriculum is going to be fair game as a CHW curriculum. It's proprietary right now. We're trying it out to see what it does. But if you are in the PCORI project and you are in the peer mentoring site, we're not. VCU is not. Anybody here in the peer mentoring? Yes?
Yeah, good.
Okay. Have you seen any of these materials that I'm talking about? Okay. So I helped develop them. So did Jim Ekman.
Mm-hmm.
And so did another outfit that they hired. They have lots of consultants. So we were on the phone with their consultants, and we wrote their curriculum. We wrote their scripts. We wrote everything out. And eventually that will become public domain, and that'll be something that everybody can use. Oh, absolutely, yeah.
Okay.
They're nowhere near using it at this point because they haven't even recruited all their peer mentors.
Right.
But I'm just letting you know, once they do, those peer mentors are going to get, guess what? Trained. And the training that they get is a CHW type 1 curriculum training.
Yeah. Thank you. We're at an exciting time. There's a lot of wonderful stuff going on that if we can stay connected, we can actually make some difference. Also, when we've done our training a couple times, and then you remember when Shirley said we started off, Stephanie survived from the beginning, but we had a real open and shut door. I mean, that was a revolving door going on with people coming and going. So over the years, we learned from some of our mistakes and some things that weren't as helpful. And we even at one time, I don't know if y'all remember, but one summer we actually developed a little interview, and we did what's called key informant interviews. And the community health workers that were on board at the time, which was about 6, I actually was the one that went around and on a one-to-one interviewed every single community health worker with some standard questions and did qualitative research. I didn't want to do a survey. I wanted to hear from them. And I got an earful, okay? But from that, it really helped us mold, oh, gee, we need to do a better job of. So from that, we realized that motivational interviewing needed to be expanded and really hit hard from what we had done initially. We needed to talk more about setting boundaries. So therefore, even in this training, Shirley did some good information about setting those boundaries, and you have some wonderful handouts on do's and don'ts and setting boundaries and what makes a good home visit. So that's why that's in there. It was our way to make that a little stronger. Safety issues was another topic that came up. Community engagement. Remember they talked about, we thought we knew it all about how we were going to go out and recruit patients and engage the community. We fell flat on our faces, all right? So we've learned some lessons. Now, the problem with some of that is that we learned that for the study, we can use patient databases that are right under our noses. But there's another group of sickle cell patients out there that are not tapped in that way. So we've got to get creative, and that's something that I don't think anybody has a wonderful answer for. Do you agree? I think that we have a whole area that we can do some more research, and that's where you guys come in. You may very well have a sense of how to go out and reach what we're saying is the more hard to reach patients. And these are patients that are not necessarily showing up in our specialty clinics, for sure. They're randomly showing up in an ER somewhere. Did you want to add something?
Yeah, who's involved in SCDAA Get Connected? Who knows how many patients have signed up? Is that proprietary information?
No, I think anytime they need to make a presentation on it, that it's about how they present. I had much more than this. Truth be told. So it hadn't been a big push. I know it was a big push like early part of last year. 2 weeks ago, NHLBI, they're in their Wednesday, whatever they're doing for Sickle Awareness Month, Dr. Whitney Sherney presented, and she broke the numbers down by the number of affected individuals, the number of providers who are on there, and then the number of like caregivers or trades. And at this, off the top of my head, I want to say it was like the total was somewhere in the 4,000s, but when you looked at affected, it was more like 3,300 or something like that.
Okay.
One would hope that that approach would attract people who are not coming to emergency departments or hospitals, but who are on social media and somehow want to have a voice and want to have company and want to get connected. I'm sorry, I don't know a better word.
Right.
But I'd like to know, we'd like to know if the people who are being attracted to that are already in care
Yeah.
or are not in care, and this is their only reach.
If I were to go out on them, I would say that the way you got connected was through member organizations. So
Yeah.
connected to care is a little bit.
They should be able to generate that, though. That was part of the question.
Yeah, but the way the question was asked, I don't know if it shows that you're currently
Yeah.
in care. Like, because people listen, they're adults listen to pediatric providers, you know. So,
Well, what I'm hearing is that this is an opportunity for us to really do some work. There's a manuscript that Shirley and I have been working on having to do with recruitment, and we've discovered that there may be patients out there that we're not tapping, and that's what we're writing to say, hey, somebody's got to step up and help us here. And this is not just sickle cell. This is through other kinds of things, and trying to use social media in a better way maybe to do some of this. So I think it's an area that we could really address and do more with, but you've been a little busy lately. Okay, another topic is planning for the unexpected. That seemed to have come up. And so that one's a little tricky, and I know Shirley mentioned a little bit, but that was a topic that we've tried to integrate. Other topics that popped up, and you can see, is person-centered care. What does that really mean? The medical home, conflict resolution, and burnout, compassion, fatigue. So obviously, you see how it got into this curriculum. That came from our community health workers and over the last few years, hearing and listening to what needs to be in a training. Pedagogy versus andragogy, and this is essentially teacher-directed versus more learner focused, all right? And that adult learning theory is absolutely critical to doing any successful community health worker training. How have you responded or felt about this conference? What were some of the things you really liked about it? Everything. I'm asking. I'm sorry.
The content.
Content, got to have good content. And for the adult learner, that's critical because adult learners don't want to be hearing and learning about what they already know. They want to build on what they learn, what they know. So y'all represent a fairly big continuum of people in that you come from a lot of different walks of life. So that's a challenge, but at the same time, we were trying to give new information for many people, but let's not forget some people may not know. So hopefully, we've somehow hit a happy medium in there somewhere. It would be a lot easier if it was just patients or just this. And so that's a challenge, but that. We tried to use technology to really maintain engagement, the mentor meters, the stopping, the different strategies to keep us engaged and moving. So we made a real effort to use adult learning theory, and we have the entire time we've been doing any training. It's absolutely critical to this kind of training. Experience. Adult learners want to build on their experience. They want to have a chance to talk and share, and we've been doing a lot of that. And we hope that you've appreciated that. All right, autonomy. Adult learners many times like to do their own thing, don't we? Yes, we do. Yes, we do. Yes, we do. And action. You want to be able to apply that information. And even though we've been here since Tuesday, I'm hoping, even though you haven't run right out and applied it immediately, I'm hoping that in all of this experience, that there's some things you go, gosh, I could go back and do blah, 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 blah. And so if everybody in this room goes back and does one action, then I think that we've made an impact. And that's what using adult learning thing. I love this photo, though. Here we are, us baby boomers. We can still get up and dance. It may not look great. And then I kind of went over this the other day about the generational impact and how important we need to be looking at that. Yes, indeedy, we need to be very careful and bring in the SMART objectives. You've got that handout in there about writing SMART objectives, and essentially, and y'all all told me that you were aware of that, so I'm just going to move right on. And obviously, this is as the staircase, as it gets harder. Things like analysis and synthesis and evaluation is your top level functions. So when you're doing some things, you've got to start at the bottom though and work up. So that you need to be aware of that. So okay, we have the SCCAPE course objectives, right? They were in your web and registration, they're in your program, and they're on your evaluation sheet. So that's part of what we're showing you. We have the short-term, our short-term objectives are related to this conference, aren't they? And all of those underneath or learning objectives were more about this conference. I want to be able to do this, list that, identify that, discuss that. Your more long-term objectives are what we're going to do with our follow-up. So if you're doing a program, that's what you want to be looking at. If you're doing training, you have objectives that deal with, at the end of the training, I want everybody to be able to identify this and that and that. But my long term for this training is I want them to go out and be a successful, effective community health worker. So you word those objectives slightly different in your planning and as you move through your evaluation. Teaching methods, we mentioned this. I hope that we've demonstrated some teaching methods. There are many others we could have done. In today's world, social media, blogs, classroom internet searches. I've used that, okay? So the kids like the internet stuff. All right, so let's bring it into the classroom, and have actually sat and had people, okay, I need you to get on the internet and do. One day, the students did not like it particularly, but hey, that's too bad. We needed to do it. But we were talking about community assessment, and I made them right there in the class and got in little groups, and they actually had to go look up data from like census data and all that. Once they got into it, they had a ball, and they really got into it because they were into the data and the internet. And so that's the kind of thing, instead of just standing up there and saying, well, today we're going to talk about, you know, the behavioral risk surveillance, and this is what it has. It was all apply it, get in the middle of it. You know, this table, you look up census for. This table, you look up that. And then we started sharing, and it got them very excited. So think of, you know, step out of the box and think of ways that you can move those objectives to just what us baby boomers, we went into our classrooms, we sat down, we took our notes, and everything was teacher directed. That is no longer going to be acceptable in any kind of educational environment at this time. It's just old hats. Tips for navigator training, you gotta gain attention. So what did we do at the very beginning of this? Right? That was a strategy to help get people going and moving and interacting with each other. Sharing your goals and objectives, seeking previous knowledge. I think we've tried to do that. I certainly have learned a lot from you, and I appreciate your willingness to share. That was not just something that happened, but it was, we tried to plan, and what we already realized, we need to build in more time for that. But you know, we learn. That's what we learn. Present essential content, and it's got to apply, apply, apply. This is what adult learning theory is all about. And by the way, the father of adult learning theory is Dr. Knowles, who's written books. I actually took a whole course in it, and one of his books was our textbook. Since then, he rewrote it about 3 times. So, encourage and provide feedback. The Mentimeter, isn't that a neat little way to get immediate feedback as what's going on? And then program evaluation. What do you think I'm going to say about program evaluation? Start at the beginning of your planning. You plan your evaluation from the get-go. How are you going to know that you've had success in meeting the objectives? It's based on the objectives. So when you develop that objective, you better have a plan. How am I going to know we met our objective? And you can do this through many ways. We talked about some just a little bit ago. SurveyMonkey, surveys with different rating scales, questionnaires, checklists, skill demonstrations, testing, participant feedback, direct observation. I'm going to teach you how to do something. I can simulate it in the classroom and see if you really know how to do it. Role play. See, we did that, didn't we? Discussion time at your tables. The cycle of training is a continuous process. And as soon as you think you've done it, guess what? You haven't done it. You got to go back, go all the way back around. It's a continuous process. Develop your course or your workshop or your seminar. You get your experts in. You develop your content. You do it. You actually go do it. You get student feedback. You make revisions. You review it. And guess what? You redesign it. Those of us who have been in education, that's what happens. Now, today it moves much faster, but in the good old days, you developed your course, you wrote your syllabus, and it went out, and you did that same course both fall and spring semester, and you didn't worry about it. In today's world, everybody is like moving so fast that you probably review and redo your course from fall to spring. That's what I've been seeing. You never are satisfied with the syllabus for any length of time, and that should be. And certainly in medicine and nursing and social work, things are moving. You cannot rely on something as being current and accurate and ready to go. Continuing education, we've talked about this a little bit. Remember that there is no national consensus on continuing education, even if it should be required. If so, how many hours? We don't even know how many hours that should be part of a minimum required curriculum. So knowing how many continuing ed hours, I don't know. Medicine and nursing and social work, they have hours, and where they got some of those hours as to what's an effective, I got a feeling somebody just took a number out of the air. I know in nursing they pretty much, it varies from state to state, but in order to keep my nursing license, I have to do so many hours of continuing ed. Where that came from, I think somebody just said, oh, well, this looks good, 30 hours a year. Oh, okay. I haven't seen any studies. I don't know what is a reputable. So therefore, if community health workers, is it 5 hours a year? 100 hours a year? We don't know. At some point, maybe they'll figure it out. Now, Shirley touched on this, so I'm not going to belabor the point, but experiential or field training, to me, is a critical part of any community health worker training. There has to be some mentoring going on, some working in the field. Do y'all do like pair people up, do shadowing or anything when you have a new person come on board? Great, because they've got to get in the real world out there. But you need to ease them into it. You can't just take a person who's never made a home visit and expect them to go out and make a home visit and know what in the world to do. I've been there as a neophyte little nursing student that got plopped into community health, and they expected me to know what in the heck to do, and I went out to Gilpin Court by myself on a home visit for community health. I didn't have a clue what I was doing. Even though you sit and you have your little home visit plan, all of a sudden I got to go out and find this lady that's pregnant in a project and be an effective home visitor? No, that ain't going to work. But a good program is going to have some planning and maybe some shadowing, some hand-holding to get that comfort level up. And then, even then, there needs to be that supervision. So there has to be some supervised field training. Also, I'm not doing this because Shirley already went over this, the team meetings, daily check-ins, all that good stuff. The scheduling, logical flow of content, if you're doing a flow, and they can get all messed up, like just this afternoon, Daniel really needed to go to class, so we had to switch it. So you just learn to be flexible about that kind of stuff. You try to build it that's a logical flow of content. It's like building blocks. You want to make sure you give the information that person needs early so they can build on that. Have any of you ever had an experience of where you got into a class and you were lost from day one? Anybody? Yeah, what? What, can you give us a little bit? What kind of class was it? Any of you taken like chemistry?
My freshman year of college, I had to take this goes on my age. I was signed up for Turbo Pascal, which is a programming language that's not used out anyway.
Oh, okay.
But that was my first experience with a programming class, because I decided I wanted my major to be computer science.
Yeah.
And when I sat in class, I literally was around like, do you understand what this man is talking about?
Right.
I was so lost in that class.
So
from
lost.
the first day. So like
Right.
speak a foreign language.
Right. That's what perfect example, and that's what I'm talking about. You cannot expect people to be able to get concept A up there on the top if they haven't gotten concept B and C yet. I took organic chemistry and I was lost from day one because I found out that my chemistry that I took back many years before was so out of date that they're starting talking about organic chemistry, and I love that. I mean, I saw the chart up there and I went, boy, there's more things up there that used to be, you know? So you see, I mean, you've got to have a logical flow of things, and sometimes that works good, and sometimes it doesn't. And sometimes that's what experimentation is all about. Have some fun, use technology, we have it, use it. And this is really from me. Designing and implementing a training for sickle cell disease, community health workers, or health navigators takes planning and patience, but it can be one of the most rewarding experiences. Seeing community health workers assume their role and make a difference in a patient's life makes it all worth it. And I do thank you. I've enjoyed it. I'm going to ask, come on, Shirley, Dr. Smith. I'm going to ask Dr. Smith. We're done! And what is it we got to say? Celebrate life and lessen the pain!
Nothing else to say. We just thank you for your time and your energy, participation, and we do want to do it again, and we certainly want to expand the reach. Y'all have a safe trip home, and we can take a bow, y'all. Evaluate us, evaluate us, evaluate us. Did we mention we wanted you to evaluate us?
I may have forgotten to do that.
And in between now and December, if you're starting to prepare what journey you're going on, feel free to reach out to us and we can help maybe set up some kind of plan, and then we have the December phone call, kind of see where you're at. We can always do sidebar conversations with any of you, okay?
And I think we'll probably, with some of this, we'll figure out, we may even send emails about what topic may be our topic for December.
Yeah.
I think right now, instead of us just picking a
No,
topic,
no, we're not picking it.
we'll wait and see what, once you get a chance to let all of this sink in, and then we can.
Once again, thank you to our audiovisual team. You guys were great. Thank you.
You're also going to get a post-test link in the mail, like you did for the pre-test. I think Daniel might have told you, if I get around to it, I'll try to send it Monday, if not Tuesday.
You'll get
Okay?
it. Y'all have a safe journey. Okay, how do we turn this off properly?